Welcome to Lymphatic Insight, your go-to podcast for unlocking the secrets of optimal health through the lens of the lymphatic system. Kindly sponsored by Flowpresso and Flow at Home products. Each episode features enlightening conversations with leading experts as we dive deep into the vital role of the lymphatic system. Tune in and discover how enhancing your lymphatic system can elevate your entire well-being. Today I speak with Dr. Robert Whitfield. Dr. Robert is a board-certified holistic plastic surgeon and a global leader in breast implant illness treatment. Specializing in advanced breast explant procedures and innovative techniques like the no-cut facelift, Dr. Whitfield combines surgical excellence with a holistic approach to patient care. Based in Austin, Texas, Dr. Whitfield is recognized for his expertise in oncology and microsurgery, which sets him apart as a pioneer in the field. His groundbreaking Strategic Holistic Accelerated Recovery Program, known as SHARP, exemplifies his commitment to optimizing patient recovery through personalized care strategies. SHARP integrates advanced testing and tailored management techniques, setting new benchmarks for holistic healing and surgical recovery. Dr. Whitfield's contributions to the field have earned him consistent recognition, including spots on the Texas Super Doctors list and Best Doctors in America. His dedication to breast health and patient-centered innovation makes him a trusted authority in plastic surgery. In addition to his clinical work, Dr. Whitfield hosts the acclaimed podcast Breast Explant Surgery and Recovery, where he shares patient stories, discusses cutting-edge treatments, and explores the latest advancements in the field. His insights continue to influence the landscape of plastic surgery, making him a sought-after resource for medical professionals, media platforms, and patients alike.
Well, hello everyone. Thank you for coming back to our Lymphatic Insights podcast. Very excited today to have Dr. Robert Whitfield join me from Texas. He's a board-certified holistic plastic surgeon and is doing some incredibly great work in the explant area. Thank you for joining us.
Thank you for having me on.
So we start this with just a bit of a fun fact because it's always nice to get to know someone on a more personal level. So what's your one? I was told by your assistant Stephanie it was to do with the fact that you'd done surgical training in England. Is that correct?
Yeah, the folks who set up our liver transplant program where I trained in the United States at Indiana University Medical Center were from Cambridge. So we had an exchange program with them. And in the 90s, it was a pretty brisk exchange. Registrars would come from England, and then our, counterparts, the residents from our program would go there. And that went on for a period of time. And there were some changes in our system that probably dampened that. And so one of my, training partners in residency was a few years ahead of me, said, you should really go, you would enjoy it. And I went, and I think I'm one of the few Americans who's worked in both the NHS, which is a socialized healthcare system, and our system, which is a insurance-based model for the most part. And then we have cash pay as well. It's just a very, I found it very enlightening to be there.
Well, one experience. You have to try New Zealand sometime.
I know my wife wants to go to Australia and New Zealand. I have to suck it up and get there.
Yeah, it's a long journey. It's worth the trip.
Yeah.
So let's just entwine a little bit of work because you are very much known for your work in the field of breast implant illness. So talk to us about that and what that is about and explain a little bit more in depth for our listeners.
Sure. So we've been operating and doing breast cancer reconstruction for a number of years. And as I wound down my microsurgical practice, so for everybody listening to this, microsurgery involves usually using a very tiny suture, and that needle is very small, and then the suture or the thread attached to it is finer than your hair. So to actually perform surgery with that, you need to operate in your microscope. So not like the microscope that you use in biology lab, if you remember that far back. One a bit more sophisticated and more high powered. And in addition to that, I did one of the first lymphatic reconstructions using a microscope in the city of Austin. So I was always very interested in both, obviously, cancer reconstruction. I did that for almost 2 decades. Very interested in lymphatic reconstruction for my breast cancer patients who developed problems with arm swelling, or those patients who developed lymphatic drainage issues with the lower leg. This was all, kind of coming to the forefront as I was kind of winding down my career. Now it's become much, much more prominent.
It certainly has. And so when we talk about breast implant illness, is there a test for it? Like, how do you diagnose it? How are you treating it?
Right. So to date, most of the testing has been done in the laboratory. There's a scientist, Dr. Mithun Sina, who has looked at oxylipin-10-home, which is created by the interaction of biofilm and oleic acid in the breast tissue. And that actually, he's measured it in his laboratory and shown that injection of that into an animal model creates the symptoms that you would see. And then there's a further paper looking at different profiles of oxylipin-10-home. So the long story short is that's coming. It's not quite ready yet. When we look at it right now, I look at genetic testing. So I look at detoxification pathways, methylation pathways, vitamin D synthesis, antioxidant pathways, glutathione pathways. We look at gut health with quantitative PCR or shotgun testing for the gut. We look at food sensitivities, IgG testing. We look at hormone balance. So we're looking at sex hormones, thyroid hormones, trying to see where people are and help them. And then probably one of the more important things is toxicity testing. So we have a lot of problems with mycotoxins, which are from fungi, mold. We have problems with heavy metal burden based on water supplies, maybe where they grew up, maybe from the devices themselves. I can give examples of how that can happen. And then environmental toxins. So glyphosates come from food because the crops are sprayed. Environmental toxins can come from plastics, plasticizers like phthalates. Then there can be things like products, parabens in products. So there's just a host of things you get exposed to, and it's really hard to give everybody an inflammation score. So traditionally, things like SED rate and C-reactive protein have been used to characterize inflammation. However, if you looked at my patient population, most of them would not have elevation in those biomarkers. They're neither sensitive or specific to what's going on in their bodies. But metabolomics, which is going to be this, I consider the next level of interpretation on blood spot analysis, will look at different chemical products. So things like palmitic acid, things like oleic acid, things like oxylipin-10-home can, and I think are the future of interpretation for this problem.
I know some research that I'd seen in the journal of toxicology actually found when they did breast cancer cases, so mastectomy, they actually found there was 1 million times more parabens in that tissue, and especially in the armpit. So that's just like considering creams and deodorants, let alone anything else. So if we switch into lymphatics a little, so from your understanding and in your professional opinion, all of this toxicity that we're being exposed to, the impact on the lymphatics, what's your view on that? And therefore, how have you considered that in the work that you do today?
Well, we've known, obviously, the most effective filtration system in the body is your lymphatic system. So for your audience, I haven't used drains in my practice purposefully in the last almost 5 years, which is probably heresy to most of the surgeons listening. But in general, you don't need to, especially for breast surgery. So for us, when we're taking out an old implant and it's scar tissue, so your body creates scarring around every implantable device. It doesn't matter what it is. And so we remove all that because it can harbor bacteria, it can harbor cancer. So that's in particular where we're doing that. And then we connect that with the tissues in the abdomen, specifically more down the flank area. And as gravity takes all fluid downward in the body, your lymphatic circulation using devices like the Flowpresso, which we have 3 in our office, that helps aid along with dietary modification, supplementation, good quality sleep, all the right things to enhance their lymphatic drainage. And then by doing that, you don't expose them to unnecessary problems with prosthetic devices, which can get infected, can be painful. And, those are probably, the most important aspects. I mean, your body's the best system if you just learn how to enhance or leverage what it already can do.
So just circling back to you don't use drains. Why? What brought you to that point from a medical perspective to not?
So breast reduction surgery has been touted to be one where you cannot use drains for a long period of time. Drainless tummy tucks have been done for a long period of time and are now almost like standard of care issues in the breast for whatever reason. It's touted that in explant surgery, a drain is this kind of necessary element, which is obviously not the case. We've demonstrated over time that's not the case. So if fluid is the whole issue, if you don't have enough space, if you collapse the space, then fluid can't accumulate. So in drainless tummy tuck procedures, they just simply make horizontal rows of sutures all the way down from the top of the abdomen to the lower abdomen, thereby decreasing the space or the dead space so fluid can't accumulate and your body can just absorb it. Your body will absorb the fluid. It's when you have a big open space that your body can't really do anything about it and it keeps generating fluid. So we just leverage, like I said, dietary protein intake's a big factor in this. So we do the higher protein diets, almost 1.5 to 2 grams per kilo of body weight. And then everybody comes here the day after surgery to get a treatment in the Flowpresso devices we have, in addition to our hyperbaric therapy, in addition to our red light therapy. And you kind of rinse and repeat that day over day, week over week. For the folks who are in Austin, they have a distinct advantage because I have all this at my clinic. And for the folks who leave after a week or two, I have people stay. People who come from, if they came from New Zealand, would stay about 3 weeks because I won't let anybody long haul flight back and forth right away after surgery to avoid blood clots. So if you're coming from, that type of distance, you're going to stay, 3 or 4 weeks in Austin. But that being said, that just allows you to spend more time at our clinic and take advantage of all the access to resources that we have.
So is there, in your career, like with knowing the lymphatics and doing things different, is there any misconceptions out there about lymphatics that you've become known about, that you've seen as a problem moving forward?
I think, the lack of general understanding about it's, to me, just like I said, the most effective filtration system. I mean, it is. That's why it exists, is to help your body transport, the excess fluid. And when people put on and retain fluid, we examine them and you can tell they're holding or retaining fluid. And typically after we start them on our inflammation support supplements to lower inflammation, and we help them do preliminary modifications in their diet, cutting out things like gluten and dairy and processed sugars, increasing their protein content, improving the quality of their sleep and the quality of their food and fluid intake, coupled to detoxification, things that promote lymphatic drainage, opening up the drainage pathways in their liver and their kidney, making those function better. If you can support them in those ways, then all the things that, maintain your body, maintain your, we talk about homeostasis. When your liver functions better, everything functions better. When your lymphatic system is really working well and efficient, swelling goes down very, very rapidly. And we really adhere to those principles and find that that's the best way that we can promote recovery. And my book, Sharp, is written about all of these things, highlighting them specifically, for what we feel is how recovery should be. It should be straightforward. In our patient population, it is. And we try to, help everybody be as efficient as possible in recovery.
So talk us a little bit more about the book and this the SHARP method, and so that our listeners can actually learn a little bit more about it.
Right. So it started, I did mostly oncology reconstruction, burn care, trauma. And when I went into teaching in my first position, that's basically what I did. And when I came to a private practice, I did the breast cancer reconstruction, head and neck cancer reconstruction, sarcoma reconstruction. And then, that evolved into taking care of the patients who didn't want their implants, who had them for cancer reconstruction or cosmetic enhancement. And then we kind of went through this whole ordeal with the pandemic. And I would send patients out to get help with functional medicine care, integrative care, acupuncture, any kind of, holistic care that we thought would help them, functional nutrition support. After the pandemic, many providers stopped seeing patients. So we had to bring on and develop our own functional team to support those patients and perform detox for our patients in a controlled manner. So as we did that from 2019, 20, 21, 22, 23, 24, and into the future, Sharp became just our method to provide holistic, accelerated recovery for these patients using functional genomics, good nutritional foundational support, toxicity testing, looking at their food sensitivities, really, trying to help them with their hormone balance. And you do all that up front instead of respond to it after surgery. So if you prep the patients and then have a strong team to support them, then have a good surgical plan and carry out all these things after surgery in the same type of manner, and you're consistent with it, and your patients can be consistent in those behavior modifications you've tried to instill, the outcomes improve because they recover faster, more efficiently. And the whole book is just highlighting all those things we learned over the last several years, taking care of thousands of patients for both cancer and cosmetics in my practice, and leveraging that experience.
It's amazing. Be a great read. So, my background is obviously working with breast cancer patients. So, and I had the fortunate opportunity to be in Holy Redeemer Hospital in Pennsylvania and actually got to watch bilateral mastectomy, but also implants being done by a surgeon there. And it highlighted a lot for me, both on a structural point of view, but what depth of trauma goes on. And, one of the things I'm sure you're fully aware of is the emotional aspect to breast cancer, and then subsequent the why of putting the implants in. So in your findings in the last 5 to 6 years of working in this industry, can we talk a little bit more about the signs and symptoms that implant may be affecting someone's health and wellness, and therefore, and the why? Like you talked about scar tissue, which is significant, and obviously what goes on around the implant. Can we just deep dive a little bit further in that for me?
Sure. So my first experiences with this were really early because I did a tissue-based reconstruction called the DIEP free flap. And so I would take abdominal tissue connected to the blood vessels without taking muscle, and then perform a breast reconstruction. So I had a kind of different, niche in terms of what I was exposed to routinely. Because in community-based hospitals in the United States, the plastic surgeons in those areas would predominantly perform implant-based reconstruction, whether it's tissue expander in 2-stage with a permanent implant as the second phase, or a direct implant, however that ended up. And our country, the United States, is such a big country with 330 million people, but it's spread out significantly. We don't have the densely populated cities in terms of, New York is a densely populated, New York City is densely populated. Most of the countries, unlike that, it's very spread out. I'm in Texas, basically the largest state in the United States, and you can drive 12 hours and still not get out of this state. So for us, my patients would come to me mostly with implant-based problems, not because we had placed the implants and they had developed a problem, but because they had went somewhere else, had therapy. Maybe they had radiation therapy, which was a predominant, problem with implant-based reconstruction and radiation. Then we get capsular contractures, thinning, extrusion, all these different things, infections, etc. People were undergoing chemotherapy after tissue expander placement, could get an infection. So there's all sorts of reasons that someone would have been sent to us in a referral type pattern to what's called the tertiary medical center, which is where I worked. And then I would have to figure out what to do for them. I will tell you, even early in my career, I knew if I took all that material out and all the scar tissue out, and I just did a reconstruction with their own tissue, which was like their own genetic material, that all this stuff would calm down, whether it was infected, and if I took out radiated tissue or problems, even those would improve. And back then, when I first started this in 2004 and 5, when I began doing deflap reconstruction, I didn't have all the wherewithal, nor was it even part of the programming and discussion in the world to do lymphatic reconstruction. Like, it wasn't part of that. And year over year, things would progress, and lymphatic reconstruction was being discussed first out of Asia, and then when we go to meetings, and specifically a meeting in Taiwan I went to in the kind of late 2000s, and then again I went to other meetings, and they would just show these results that were shocking in terms of people who had bilateral lower extremity lymphedema, and it was resolved with lymphatic veno bypass, connecting the lymphatic system to a very, very small vein is called a venule. So they would connect it, and it would just be like, why in the earth? How is that even working? Because pressure dictates flow. And if you have a super low flow, if you have a low pressure system, you would think, how is that even working? And they would show these results. And I remember 2 really famous plastic surgeons getting into an argument over it. And I was like, oh my gosh, I didn't even know. I was a young person. I was like, this is, super strange, but okay. And year over year, these things would come, and the experience would grow, and more people would do it. And they're doing lymphatic veno bypass. They're doing vascular, oh my gosh, lymph node transfers. After, hooking up the vasculature. So all these things were changing pretty dynamically, but it was happening, in my career, it was happening outside of the academic setting. So this was in a private practice setting, and we were trying to do this work and help these patients. And it was kind of early in that experience around the world, especially in our country. It was very early. And then I stepped away from doing microsurgery and had to wind down that part of my practice. And now I wouldn't say it's, available everywhere, but it's much more common to have that It's very difficult surgery to do. I will tell you that.
Can imagine. So just so we can circle a little bit back to the lymphatics. So obviously with breast cancer, and often more than not, there is lymph nodes removed. And, a lot of women become deeply concerned about how many they've had removed and how many they've been involved. So, do you see a correlation between the impact of these side effects that you often see with breast implant illness is there a relationship to the amount of lymph nodes removed? Does it increase the option of getting an increased amount of illness associated to that breast implant? Have you seen anything in your career?
Well, currently I'm seeing more patients who were from cosmetic enhancements rather than cancer reconstruction. I usually will get asked to consult with a patient about a cancer reconstruction from a colleague whose patient has experienced a problem and they're trying to answer a specific, question. I am not, from an experience standpoint, doing a significant volume of patients with that history.
Mm-hmm.
So I can't really comment if that is a factor increasing in the cancer patients. Now, with the advent of sentinel lymph node biopsy, there should be far less lymphedema, but it still obviously happens more often than obviously anybody would ever want. But that certainly changed. I always joke with people, like, I saw all these things change in training. I started training, then we're doing modified radicals and complete lymphatic axillary dissections. That's what I was taught. And that's what I did as a general surgery resident. And then we switched to doing sentinel lymph nodes. By the time I was done training, we never did an axillary lymph node dissection anymore. And we also were taught to do open gallbladder surgery, but by the time I got done training, we were taking them out with a camera all the time. Right. So all that stuff happened for everybody listening while I was training. And I was training for 6 years in general surgery before I did plastic surgery for a couple of years. And then I did microsurgery and other reconstructive surgery for another year after that. So that's a really short time frame to go from doing one procedure to another procedure, setting a whole different standard of care in two different types of patients. So, we should see a decline in the lymphedema, which we did. Still could happen, unfortunately, in terms of lymphovenous bypass. Don't know the current data on where that stands. So I can't say that I've seen enough to comment on it.
And okay, going to the cosmetic side, bearing in mind that, lymph nodes aren't actually that easy to see. Do you think that they're damaged at any point in those kind of procedures? I know surface lymphatics are, but do you think lymph nodes are?
So we do, because there's lymph nodes in the breast. We're trying just to take out the scar capsule and leave as much tissue behind as possible. So the answer is we're always trying to preserve tissue. And because I'll get asked routinely, do I take lymph nodes out? And the short answer is I would never intentionally take a lymph node out or try to disturb the lymphatic tissue because it's going to come with consequences. So no. I would never do that. I know better. You don't mess with the lymphatic circulation at all. You try to avoid anything to do with that. So I'm not up in the axilla either. Like the most worrisome cases I will tell you is people who have had an axillary approach to breast augmentation because they have scar tissue that goes into their axilla. So they're the most at risk for a problem with that.
And what about axillary coiling? Any comment on that or your experience with that or having seen that in your career?
Yeah, we've seen it. It's pretty. So I have a lymphatic therapist in my office as well as all the flow presso devices, and we're aggressive with all of these up front. Mm-hmm. And our therapist works with patients to help counsel them. And we have a lot of communication with them if they're experiencing, additional swelling. I will say that it's pretty routine that one side drains more efficiently versus another, as you would imagine. Everybody's different side to side. They're very, very common where one side will drain more efficiently. So we haven't seen so much cording, but just more fluid accumulation. Once again, we're not trying to be in the axilla. We're trying to just get the tissue, the scar tissue, away and not be as lateral as you would imagine. That would lead to more of that issue. So I don't see that. Even in really thin patients, we've, fortunately avoided that.
Well, that's lovely to hear. So just going in back to the breast implants situation where you've extracted, what would be one of the biggest cases you've had to deal with that's been the most significant to you in your career? Like the findings of once you actually, I've watched some of your YouTube, well not YouTube, your Instagram posts, and I've seen you take, show some of the pictures and some of them look quite extreme. So what would be the one that still you've not forgotten to this day?
Well, we have a patient, breast cancer is still the most prevalent cancer we're going to run into. And we send everything off for testing all the time because my whole background's in cancer reconstruction and cancer care. My sister's a breast cancer patient who recently passed away this year. And we don't want to have or leave questions for patients to think about. So I sent off material, and actually today I was called by a pathologist because someone had ductal carcinoma in situ, a 1 millimeter focus. Now, it's never been picked up on all of her screening. She's had MRIs, she's had mammograms, she's had ultrasounds, but that's too small to identify. So that's a pathology diagnosis. So I'm actually surprised I don't see more of that. As much as I do, as much as I work in the space, as many as I take care of, annually, I should see a higher incidence. And so I called the patient and I said, hey, we found this, and this is in situ, meaning, we're just going to watch, and we're going to, connect you with the correct providers for surveillance, but this is what was found. Now, had we never sent any of the material, they would never know that. And so this is deep. So this is right up against the scar tissue. It's very hard to see that area. And I've had a couple of patients where I've felt abnormalities, and we've been careful and went around them. And we've found this on other patients. So, and they're, obviously very grateful that we found it. We took care of it. We identified it for them. And, I think as a team, we do our very best to make sure that we're taking, care with all the patients and sending all this off and making sure that if there's something that's going to harm them or could have long-term health consequences, we're trying to identify it for them so they can have and make the best informed decisions about their care.
Fantastic. So just to sum sort of everything up, so listening to you today, breast implants aren't always the direct cause. They are part of the cause to someone's overall experience that they're having in the way of illness. Would that be correct?
Yeah, I look at the breast implant illness as really a chronic inflammatory process. And part of it is having a medical device. It's not the only aspect of it because, as we all know, many people have and suffer from chronic inflammation that don't have breast implants.
Yeah, good point. But I think what I'm really enjoying hearing is that not only are you managing this, but you're doing a real holistic approach because, like lymphatics, like everything, it's all part of a whole interconnected holistic approach to health. Like you've got to consider everything from diet, exercise,
right.
Like you're doing all the study, the testing and that. And just one little one that we bring in is the breath. Do you see a restriction in the chest wall area when it comes to breathing? Do you find, I used to see it in clinical practice all the time, there was this kind of restriction in the chest wall where women were not getting their full expansion through the chest wall. Is that something you've seen?
Yeah, that's been shown in papers. It was shown when I was, I think the easiest way to think about it is if you take people having breast reductive surgery, and you remove the weight off the chest, they're able to take, the basic way to think of it is take a deeper breath. And that's shown with a reduction as little as a cup size, which is about 200 grams of tissue. We similarly think that when we do, explants, it's a reductive procedure because your implant typically is going to be above 200 grams. It may be on average about 350 grams if you want to think of it like that. So per side, that will make a difference in their ability to inhale and exhale. So for everybody listening, the respiratory system, everybody likes that when I say respiratory, that will improve. So total lung capacity or functional residual capacity, just basically your ability to take a deep breath. Let's just say, think of it that way. Yes, that does improve.
Well, yeah, that literally taking the weight off the chest, right?
Yeah.
Yeah. No, that's amazing. So on an ending note, is there anything that, that you feel that for listeners that, not necessarily with breast implant or illness, but just in general that you would like to portray from a lymphatic point of view, that is, whether it's a technique or methods or anything that you've just learned over your career that you think is key to health and wellness when it comes to the lymphatic system?
Yeah, I always like to help people with sleep because everything in terms of repair happens when you sleep, and your lymphatic system, to me, we're doing a lot to help promote lymphatic drainage in our office, but being really cognizant of your quality and quantity of sleep will allow your lymphatic system, I think, to help you the most, both for your brain and your body.
Yeah, it's a really good point. We've talked about that in the last couple of podcasts too, that sleep is pivotal. With the final realization that we have a lymphatics, you're saying 7 to 8 hours quality, right? It's going to drain the brain. So then alone is to encourage people, but let alone the rest and repair and recover that goes on when we're in that state to heal from illness is key as well. Well, look, I want to thank you for your time. I know you're incredibly busy and doing great work in the community of Austin and probably around the US and other parts of the world for women in this world that are dealing with this kind of illness. And it's been a real pleasure to have you and to have your wisdom. Thank you again for joining us.
Thank you for having me on. We have a growing listenership in New Zealand.
Yay. You do. And we'll have all the details on how to learn more about the SHARP method, etc., with the podcast. So thank you again, Dr. Whitfield. It's been a pleasure.
All right. Thank you.